I'm Dr. Laura Ellis, and I welcome all of you here tonight for some amazing information and science on stem cell therapy. I want to thank Crosslink Bioscience, distributor for Stryker Orthopaedics and Cytonics, helping us make the processing of stem cells possible. I also want to thank Synergistic Technologies, key leaders in regenerative medicine and stem cell therapy. Right now, millions of patients experience joint pain, facing the prospect of joint replacement therapy or surgery, along with the associated risks and unwanted potential side effects that come along with that. Stem cell therapy can provide a cost-effective, non-surgical treatment with little to no post-operative downtime, with most patients able to return to their pre-treatment activities right away, unlike joint replacement therapy or surgery. And my view, and the purpose of hosting this event, is that most of us could benefit from stem cell therapy prior to joint replacement therapy or in lieu of joint replacement therapy. And I have to tell you that that's really my own story. I'm 51 years old, and I've experienced over the past few years some knee joint pain. And I know the cartilage in my knees is thinning. And I don't want to have joint replacement therapy because I know that I can't ride my bicycle or my motorcycle or run and jump like I want to in my 60s and into my 70s and beyond. We can do those things beyond the age of 50 and 60. When you get a knee joint replacement or a hip, any other joint, it's not like your original. You can't run and jump and play on it. So I want to introduce to you today some of the innovators, the movers and shakers in stem cell therapy for orthopedics. And I'll tell you a little bit about how I use stem cells as well in my practice. Dr. Dan Eglinton, sitting to my left here, he's a board-certified orthopedic surgeon. He specializes in adult reconstructive and sports medicine surgery. 17 years experience with growth factors and 10 years with stem cells. How many people in this room know about stem cells or have heard from their doctor about stem cells? Some of you. Yeah. A lot more than the general population, I think, which is probably why you're here. You're kind of qualified. Dr. Eglinton has spoken at both national and international meetings, including Eastern Orthopedic Meeting last year, where he presented his study and the use of stem cells in arthritis in the knees. He's given university lectures, including at Duke and in Chapel Hill, among others. He's currently authoring 3 papers on stem cell usage in other orthopedic conditions, other than knees, right? And he is going to give you a talk on the science of stem cell therapy. You ready, Dr. E?
Ready. Thanks, Laura, for that introduction. I wrote that.
I had to read it.
I want to thank everyone for coming tonight and taking time out of their life to listen to... Okay. Taking time out of your lives to listen to something that's very near and dear to me. And so, as Laura said, you know, I have had experience with this over the years. And so the topic for tonight is biologics, and hopefully the talk tonight will be just a step above Sesame Street. I've given this talk several ways, and some of the people had to endure it. That's the stem cell 101, and then we have to talk about that. But tonight's talk has got a little bit of science, but an awful lot of common sense. Okay? So, the first thing that we notice, I need that slide back. The first thing we notice is this is biologics, not stem cells. That's why we're here, right? We want to talk about stem cells and growth factors. Stem cells and growth factors are part of biologics. Biologics are those elements that are necessary for the maintenance and function of living organisms. Okay? So as we go through this, we're going to see how they play a role in it. And what's interesting is they play a role in regeneration, and they also play a role in degeneration. The role in regeneration, basically regeneration is just replacing what's missing with what's missing. Simple. And how do we plan to do that? Well, we want to use you to heal you. The one thing that I know is I may not know everything about stem cells or how they work, but I do know that they work. So we're not changing the way you heal. All we're doing is accelerating and multiplying. Next slide. I too would like to thank the sponsors here tonight, but none of us up here are compensated speakers. You need to know that. I have no proprietary interests, stocks, bonds, anything like that. My only conflict of interest is basically with people that don't agree with me. And occasionally myself. And I think it did the chocolate. Next slide. So this is my practice, and it's a culmination of about 17 years, as we mentioned, of intense research and clinical usage of biologics and treatment of orthopedic conditions. About 17 years ago, I had one of those aha moments, you know, where you realize that not all your patients do well. And it wasn't because I didn't care, I didn't try. That broke my heart. But the other thing I realized is a lot of people were getting well in spite of what I was doing, because we have this wonderful capacity to heal. And that naturally leads one to do regeneration. That's the logical step, and that's what I've been doing. Next slide. So, I love this slide. Basically, this slide is put in to really pretty much say what Mark Twain said. And Mark Twain said, it's not so much what you think you know that bothers me, it's what you don't know. So tonight I'm going to endeavor to tell you what I think I know, I'm going to tell you what I don't know, and I'm going to tell you what I want to know. Now a lot of you, I got you, you thought I was talking about people that don't agree with me, weren't you? Right? Okay, next slide. There it is. Okay, cool. So this is a question basically that we want to answer tonight. Are biologics in the use of regeneration, is it a fad or is it the future? Well, if you were to ask the panelists up here tonight, we would answer, no, it's not a fad, and yes, it's the future. But if you were to ask the majority of doctors in this country, they would probably say, is this annoying? They would probably say, yes, it's a fad, and yes, it's the future. So the one thing we both agree on is that it's the future. Okay? The problem is, where do you stand? That's the real question. And that's why we're here tonight. Because if you look at this, you get your information from two sources. You get it from media, from the internet, magazines, newspapers, and those tend to focus on the sensational part, okay? Then you get the other part from your doctor. And your doctor says, I don't know that much about it. We're 4 to 5 years out. Okay, you don't know that much about it, but you know that we're 4 to 5 years out. Wow. Okay, so who told you that? Well, so-and-so. Well, that's strange because I went and talked to them when I spoke at the university. And I kind of came away with the impression that they'd read the Cliff Notes, but not the book. And that's the problem. That really, truly is the problem. So who do you believe? And that's why I mentioned the Mark Twain. I'll be as honest and open as I can. Everything tonight is in the American literature, okay? Somehow there's a bias against European literature because they feel like they're maybe not the same standards of medical evidence. So we're going to let's go on. Okay, so if we want to talk about something, we have to know where we started, right? And where we were with growth factors started in 1968 with Ellis, where he was able to concentrate and isolate growth factors from blood. Not much has happened in 47 years. Marshall was credited with the first use of stem cells for a medical condition, and that was 1978, 37 years. Now, I mention that, and this is something that we can bring up in the discussion, but why we haven't progressed is absolutely fascinating, because there are some pivotal events that happened during this period of time, okay? So where we are depends upon what you know, okay? And I can guarantee you the people on this panel are in a different place than where everyone else is, okay? So it's pretty hard to know where you need to be if you don't know where you are. It's important to know that the difference between where we were and where we are is very small. There's not a whole lot of difference. But that's important because that's the underpinnings. That's the reason, the motivation that supposedly supposed to drive this, and it got stopped. Okay, so the trouble with biologics is that it's not conducive to math and reading. It is conducive to people who have trouble with insomnia, and I can attest to that. Basically, in all fairness to your doctors, okay, most of the reading that they get, they have to do in their specialties because, you know, you have to see 1,000 patients a day now to make it. You have to do all the surgery, cover call, come home, try to read about what you're doing, and then try to take care of a family. There's not a whole lot of time for this, so I understand that. I also understand that in order to understand this, it takes a baseline level of knowledge. Well, most of us got our biology, cell physiology, and biochemistry our second year of medical school, and we're glad to get rid of it. Okay, but that baseline level of knowledge has significantly risen. And if we agree that the future is biologics, then that means that the doctor in the future is going to be a biologist more than an interventionist. We've got to get going. Okay, next slide. So this is how a lot of people think of me, okay? And that's not true. I only look this way when I get my tax statement. But really, honestly, it's not about me, is it? It's about you. That's why we're here tonight. Okay? It's about you and your health care. Okay? Can we go back to that slide? Oh, no, I need to move. Anyway. So it's about you and your health care. So before we go on, we need to dispel some myths right now. So let's go through some of the myths that you commonly hear. The first myth that I commonly hear is stem cells and growth factors, which we'll talk about, are not FDA approved. Has anyone heard that? Yeah, I think we all have. That's a half-truth. The real truth is they don't have to be approved. They never did. Under the Human Cell and Tissues Act passed by Congress in 2009, all that we're doing here is totally legitimate. And in fact, if you apply the same standards that they asked me to do right now, for blood, for bone graft, skin graft, they would have to have a study, not me. What's really interesting too is that your doctor has done a stem cell transplant. No. You're kidding me, really? Yeah, each unit of blood, each ml, has 2,400 undifferentiated stem cells per ml. That's over 100,000 stem cells that you could purchase. And you better hope there's cells in there, because that unit would be dead by the time you transfused it. The other thing that's interesting is there are techniques. One technique is in Israel called apheresis, where I can specifically take out of your blood those cells that will grow cartilage. Did you know that? That's available in Europe. It's available in the Philippines. It's available in China. It's not available here. The second myth, it can cause cancer. It can cause rejection. We use embryos. No, no, no. There has never been a reported case at the level that we do that causes cancer. It can't, because you have an intact immune system that would take care of that. Number two, there is no rejection. And studies show that even if you take amniotic cells from full-term babies, there is no T cell response, or what we use to measure rejection. That's been proven over and over and over. We don't use embryos, not in clinical practice, and they use them for experimental and in larger institutions, but we don't need to use an embryo. So, what's the other myth? It's experimental. Well, if I'm not mistaken, every time I give a pill, or I do a surgery, or anything, it's experimental. That's a half-truth. Because in reality, everything has a complication or a side effect, okay? And I can't predict the outcome. Therefore, every treatment's experimental. And all you have to do is watch TV at 6 o'clock when the erectile dysfunction ad comes on, and you hear all the side effects, okay? The next thing that I want to dispel right now, and that is standard of care. Standard of care is a very slippery slope. Standard of care is determined by clinical practice guidelines. These are set up by committees of specialists in those areas that determine what your standard of care is. And there's not universal agreement, trust me. These are based on studies, and some of the time, some of the studies used to discredit the studies are as poorly designed as the studies that we're finding. Okay? Yes. What that means to you, though, is that committee determines what insurance will pay for. Right now, these are not covered by insurance. I'm not saying that standard care is not necessary. It should never, though, be a fixed standard. It should always be reviewed constantly, lest we end up with a situation at the turn of the century where Lister, who was watching surgeons in England operate barehanded, said, no, you got to do something. They threw him in prison and killed him. That was standard of care. And guess what? 5 years ago, we did almost the same thing to the guy that ratted out the NFL on their lesions in the brain. That guy got so discredited that he's now a pathologist in a corner in a small town in Northern California. And that just happened. Okay, so let's go on. We gotta go. So the other thing that I hear is there's no levels 2 studies or 4 studies. We measure studies by their significance. A level 2 is the gold standard, a double-blind, controlled, randomized study. And guess what? If you look up here on Specialty Update, Scott Rodeo, who's at Mount Sinai, one of the leaders in regeneration, summarized where we are. We had a beautiful level 2 study this year, documenting exactly what I showed 4 years ago when I spoke in London. There are 2 other studies that were level 4 studies. One had a 4-year follow-up on stem cells. I have patients in here tonight. I think we have people in here that have had stem cells greater than 2 years. Would someone want to raise their hand if they have it? Okay, there's your study. Okay, so anyway, so there's better studies. They're coming out. In fact, there's 1,800 studies right now in the mill. Did you know that? Yep. And right down the road here in Charlotte, they're doing a study. Okay? And I know that because I'm getting patients that don't want to be in the placebo group. Yeah, true. Next slide. Okay, so this is my study. These are progenitor cells. They're kind of colorblind, but I think I get to use my pen. Okay, there you go. These are bone cells, are going to be bone cells, and these are going to be nerve cells. They're absolutely gorgeous, aren't they? So basically, what all this jargon up here means is I took stem cells from bone marrow and I used them to treat arthritis in the knee. Next slide. We're going to really go through this. So basically, as Laura alluded to, we got a problem. We've got 44 million people seeking treatment for an arthritic condition and 22 million people receiving active treatment. But guess what, guys? It gets a lot worse than this. There are 472,000 total knees done last year. Average cost is $65,000 when we measure across the country. It's projected by the Congressional Budget Office that number will increase 674% in the next 3 years because of baby boomers, i.e. moi. Okay, what does that translate to you? That translates to 3.4 million total knees, primary, not anything else. Okay, that additional cost is $42 billion a year for just that, as far as the eye can see. So whether you think this applies or not, you're going to pay for it. Next slide. So these are recommendations from the American Academy of Orthopaedic Surgeons, and these criteria have not changed in 15, 20 years. The only difference has been if they strongly recommend or strongly don't recommend. There's only been 2 changes. Do I agree with this? Of course. Because done the way this is here, we have 20 years of experience that it doesn't work. But if you look at these things and when they're used and how they're used, you get a whole different picture. So that's where we need to go in the future. Next slide. Okay, so the next couple slides are just showing that my study that I know is the only study that has criteria. Inclusion, exclusion criteria, who gets it, who doesn't, who's a winner, who's not a winner, and how to do it. Next slide. Okay, so we do things before you have them. Next slide. You can't, not everyone gets them. There's certain people that can't have them. Next slide. And there's even more. We always include pregnancy. You have to, I think you have to just put that in no matter what. I mean, if you know someone who's pregnant or you talk to someone who's pregnant, you just have to include that in the study. Whatever. So I just threw it in there, okay? Next slide. More facts that tell you, to me, these are what make winners. And if you go to outcomes-based medicine, that sounds good, doesn't it? That's what we all want, right? Well, how do you get good outcomes, guys? You pick winners. That means not everyone's going to get totals. Okay, that means healthcare rationing. Next slide. See, Katie, it's going fast. Next slide. Okay, so anyway, I did 96 patients from 2009 to 2010. And this is what you normally see, more females than males. Arthritis, degenerative arthritis is mainly a female disease, more so than a male. And this 15-year-old here we put in because she had a strange condition inherited called Ehlers-Danlos. And she kept dislocating her knee and knocked everything off. So she got stem cells because you can't put a total in a 15-year-old. The average age was 61. Basically, a third were right, a third were left, and a third were bilateral. These are range of motions. Let's go on. And the way that we could do it then was we had to measure what your pain score was. And this Tegner score is a measurement of function. And that's a problem with biologic studies because you have to prove that there's absolutely positively growth. And we didn't have standardization in the MRIs 5 years ago. We didn't have techniques for that. We didn't have ways to show that it's growing. But guess what? Now we do. One of the companies here tonight has a test called FAT, which is a biomarker. That's fibronectin aggregate complex. Forget that. But what it tells you is you can measure inflammation, and if you don't see inflammation by inference, you know you probably have growth. That's $14. If I measure the exact things in the knee, which I can send to Stanford, so I can measure these things called cytokines. Wow, cyto, cell, kines, activators. So I can measure those activators that regulate growth and those that regulate inflammation. And basically you'd have to have 3, so that's $1,000 for each patient. And that's why we have trouble with studies. Because this study alone was $150,000 minimum out of my pocket. We have Dr. Don Russell down here, a good friend of mine, who's doing a study on lung cancer vaccine on his own has his own cell block. And I don't even want to tell you that he spent no help. So I really admire him. Okay, so one of the things that's really interesting, 10% of people lost weight. When I put in total knees, they gained weight. Why? You get out of free jail pass. That's what happened. So you don't have to do it anymore. So about 85% stayed the same and 5% gained weight. But look at these. What does that tell you? Some of these people that wouldn't have gotten total knees got total knees. Okay? Because their BMI was over 30. But yet, by doing this, we were able to decrease their pain enough and increase their function that they now became a winner. Isn't that cool? So at the end of the year, next slide, 6 out of the 96 went to total. And so those 6 that went to total, I was able to take the sections from their knees, next slide, just hit it, and I was able to assess whether or not it worked. These slides that you see right here, no one else in the world has but me. I have 6 sets of these. Because in our country, you can't biopsy. So what's happened here is on the left-hand side, this is not a crater in the moon. Okay? This is arthritis. Real easy. The purple is your cartilage, which is white, and the red is bone. So to paraphrase Johnny Cochran, if there ain't no red, it's dead. Okay, so we're seeing right here, all my little things dying here. Oh well. We see it's turning pink, it's dying, we see where it's actually absent. And the problem is that from this slide, we get 2 things. One is we see that the cartilage depends upon the bone. And I think, and it was my feeling 4 years ago when I presented this, that arthritis starts in the bone before it begins in the cartilage. And Mayo feels the same way, because they just came out 6 months ago with a big news press thing about it. The reason is that the cartilage, the white stuff, has no cells and no blood supply. So if you look to the right, see those purple things there? Those are blood vessels. Oh, so you got a blood supply now. See all this red? I got new bone. Wow, you see all this? That's new cartilage. The rub with this from the guys is that this isn't normal cartilage. And that's true. 80% of it is, and 20% isn't. See the red in here? That's type 1 collagen, not type 2. So they said, well, it's hyaline-like cartilage. Okay, so maybe you're not walking on a shag carpet, you're walking on a pile carpet. But you'd probably rather walk on that than concrete or a piece of plastic. Okay? The point that I'm trying to make is if your doctor says you need a total knee, you need a total knee. We have excellent doctors in this community. We have very fine orthopedic surgeons. We have a wonderful hospital facility, state-of-the-art. That's not the issue. The issue is when do you need your total knee? Because when I looked at my patients, is that the final slide? Okay. When I looked at my patients, this is a full knee section, okay? And everywhere I punched a hole and I put in stem cells and planted, cartilage grew. Okay, next slide. This study was done at Cornell on horses. Look at this. Exact same thing in horses, okay? Shows the exact same thing you saw before. Next slide. This was Buddha, who presented at the Academy of Orthopaedic Surgeons in 2010. He shows the same thing. See the red down there? See the purple on top? He did soccer players in Italy, and he does the exact same technique, pretty much, in terms of obtaining what I do. The interesting thing about this is that his technique is in the manual or the monogram for treatment of cartilage defects put out by the Academy of Orthopaedic Surgeons, but yet it's not accepted. I don't understand it, okay? Anyway, what I want you to notice is see this 2010? All the other studies were 2010. There's your 4 to 5 years, guys, okay? You just got this year those studies that documented what we showed 4 or 5 years ago. Do you think I'm there? Do you think I'm right here? No. I'm 4 to 5 years ahead of this. And the reason is because I know now that I've got to stop that fibrous cartilage growth from coming in. And we're going to show you how that happens. Let's go. Next slide. So basically, this is what the studies did. We're not replacing total knees. We're trying to delay. We're trying to make losers into winners. And there were 3 reasons why people wanted to have these. Of those 6 patients, I asked them, knowing that you were going to have a total knee, would you have had the stem cells? And 4 of the 6 said they would. I was shocked. What were the reasons? Number 1, they wanted to make sure they'd done everything they could before they had it, because they'd kick themselves from here to Mount Pisgah back if they had a problem. Okay? Number 2, they couldn't. They were taking care of their invalid father. Their father broke a hip. Or they had a daughter graduating from high school. Or someone was getting married, or they were going on a 50-year wedding anniversary. Or, like me, they're in solo practice and they lose their practice. And the third reason people said they do it is they weren't going to get it anyway. Their BMI was too high. Their A1C for diabetes was too high. Their blood pressure was not right. But by doing this, you lowered those things and you helped them. And they were able to have it. Next thing. So, next. Yeah. So, now we're going to get into nitty-gritty. So we're going to start clipping now. If you look at this, this really means force for the trees. If the force represents arthritis, then you have 2 groups of people. You have those who are focused on regeneration, and then you have folks that are focused on degeneration, okay? The problem is that if I'm focused on just regeneration, and I don't pay attention to acid rain and maybe a forest fire on another part, it isn't going to work. Next slide. On the other hand, if I'm totally focused on the forest and I don't pay particular attention to the trees, in other words, if I'm so concerned about the inflammatory process, what good does it do to stop the inflammation if I got a big hole in the bone? Okay? So basically, next slide. So the thing is you got to treat them both at the same time. So it's not just stem cells and growth factor. You have to treat the patient. You have to treat regeneration and degeneration at the same time. This slide also brings up what Leonard Bernstein said. He said, old men, I wish he'd have said older, but anyway, plant trees that they'll never see grow. But they do so, I think, he didn't add, because they see there's a need and they know when and where to plant. Let's go. Next slide. So this is how it works. We have the in vivo. Get it? These are what we do. These are your doctor things. This is how we treat people. Next slide. The in vitro is what happens in the lab. These are your PhDs. And they're concerned with the biology. Don't worry about all this on the right, just the biology. So the trick is, hit it, the better I match the biology to the better I match my intervention to the biology, the better my result. And a lot of things, when we start looking at it with that magnifying glass, they don't make sense, some of the treatments that we do. So we need to become biologists. When we do that, then we can make logical decisions on how to treat it. Next slide. So we're going to use the example of grass. Okay, so to grow grass, you got to have topsoil. Now that's called a conductive scalpel. Forget that. You don't have to worry about it. You got to have soil. Then you got to have fertilizer, right? You got to get some roots started. Next slide. Then you got to have the seeds. The next slide. Well, if you're not careful, there's wind and rain, and those seeds will blow away or wash away. So you have to have a carrier. You have to have something to hold them down. That's the straw. And the most important part is the sun and the rain. That's the extracellular matrix. What is that? That's this primordial swamp that sits between the cells. Okay, and it's got everything in it. It's got all the messages that tell the cells what to do and it allows this cell to talk to this cell. But like a swamp, if it doesn't move, okay, it dies. So you've got to push those messages. That's why in nature we have three forces called bioreactors, things that push that fluid. In the case of bone, it's weight. That's called hydrostatic. You push down, it pushes the fluid. That's why you have to put weight on these things. One of the protocols for the surgery for those holes is not to put weight on them. That doesn't make sense. Doesn't follow the biology. Now, in the case of a tendon, it requires the forcing tension, okay? Because as you stretch it out, it decreases the volume, creates pressure, and pushes it. Well, what do you do for an organ? Well, that's called shaken and stirred. That's hydrodynamic. So, how many of you saw Leap of Faith on NBC about the Italian doctor, thoracic surgeon, who's regrowing tracheas? He was brutalized too. But anyway, what he did, is and still does, is he takes cells and pounds them, spins them around. So when you make an organ, the cells bump each other, and that's how they work. Okay, so that's all I need to know, right? To grow grass? Wrong. I wish it were that easy. You need all those things, and every one of us on this panel up here has to have those things when we do what we do. Every one of us has to pay attention. That's the basic principle. There may be some modifications in terms of, say, the pores. If you're doing a vampire facial, you may be using a roller to push it in, okay? But it's the same principle, okay? It doesn't change, okay? So we're going to look at two specific growth factors, okay? We're going to look at the fertilizer, and that's called PRP, platelet-rich plasma. And next slide. So we're able to obtain growth factors or fertilizer that are these real messages that tell the cells what to do from the platelets in our blood. That's a platelet. And so what happens is you bleed and you put a platelet there. And the calcium in the blood activates that platelet and it opens up, kind of like a rose. And it releases the pollen. Those are called the alpha granules. And there's 21 growth factors in platelets. There's actually more than 21 growth factors, but in platelets there's 21. Okay, so isn't that cool? You start healing the minute you're injured. Remember, we're using you to heal you. Okay? So why, oh why do I give someone an anti-inflammatory when they're injured? This makes no sense. We give them anti-inflammatories because we don't like pain or swelling. Well, the pain and swelling is moderated by the white blood cells. So if we take the white blood cells out, guess what? No pain, no swelling. We get all the good effects of the growth factors. That's what the newer systems, that's what Laura's using. It's called the pure PRP. We lower that white cell count. And Sean and you're doing it too. Aren't you, Paul? Yeah, they're using it too. And it increases their platelet counts. Okay, so they get more growth factors. Next slide. So this is the old version. This is not what we see now, but what we want is right there. That's where it's called the Buffy coat because it's white, because of white blood cells. So now, when you get the things that we're doing, this is almost clear, just with a very, very tiny amount of tint to it. Maybe a little tiny pink. Okay, so what is a stem cell? Well, by definition, a stem cell is a cell that can reproduce itself. So, depending upon where that stem cell is in maturation, depends upon what kind of cell it is and what it does. But what's interesting is this cell has a little tail right there, and that tail sits in that goo, and that's how it gets the messages. It's called a primary cilia. Next slide. Oh my gosh, this thing is blowing me away right here. Okay. We go through this, okay, and we're not going to go through this heavy. We all know this. We learned this in the 11th grade, about what happens here. And then, Saturday night, whatever. And then we have an embryo. And an embryo is an embryo for 8 weeks until it implants. Okay, and then it's called blastocyst. I think Dr. Wilson can correct me if I'm wrong on that, but I think that's right. So it's only an embryo for 8 weeks. After 8 weeks, it becomes a fetus, and the mother delivers a fetus. It's a baby when you cut the cord and it starts breathing. Up until then, it's a fetus. So in a fetus, every cell that's in there is an adult cell. So we're down here. Who is done? We're right here. That's the cells that we're using. So when you say stem cells, what cells are you talking about? That's the first thing you got to know. So there's all kinds of different stem cells. So it's important that we know when someone's talking about stem cells, what they're talking about. The point is, as you go down the line, it gets more specific. As you go up, you get more reproductions. Okay, next slide. So a good way to look at this is an embryonic cell is the universe, okay? And pluripotential cells, which is the next step, these are undifferentiated cells. That's the galaxy, the Milky Way. There's that chocolate again. And then up here, we have a constellation. So we're right in here. That's where we're functioning. You go all the way down to a star, okay? That's one cell, one response. That is, the chondrocyte makes cartilage, an osteoblast makes bone. Okay, real easy. Next slide. So basically, as it goes down, it begins to decide what it's going to do. So we have 3 cell types. We have ectoderm, nervous tissue, endoderm, organs, and mesoderm. This is where we all are, right here. So on this last part right here. Okay? Next slide. So these are the sources of stem cells, okay, that you can get. Primarily the ones that we're using right now are bone marrow and amniotic cells. Those are the ones fat you hear about, and there are advantages and disadvantages to all those. That's in the question and answer period. We're not going to go into it, but that's basically the level we're at. What we're doing is this and this. Okay. Oh no, what's this? Oh boy. Well, in 2010, boy, 2010 was a big year, wasn't it? In 2010, we found and figured out all the genes in the human body. And guess what? Every one of those has a patent. So if I want to do research on breast cancer, I got to pay the guy that has a patent for that gene. Dr. Russell can tell you all about that. Anyway, what's important here is that between the genes are other things. They're called regulatory genes. They tell those genes what to do. So what have I done in the last 4 years? Well, I've gone from a stem cell thing back beyond that to a regulatory gene. So what am I talking about? Remember that stem cell? Think of that as a NASCAR race car. Okay? That car can't do anything unless I have a driver. And that driver has to get the message to start it and to drive it. Okay? The messages that he gets and what we do is called cytokines. Remember we talked about those things? They activate the driver. That driver is called a regulatory gene. What's important about that, and we'll learn as we talk about health programs and things you can do, the cool part about that is not only are there messages inside of us that turn on those genes, but you can do it too. You can turn these things on. That's what's cool. So if I want to grow more cartilage and I want to grow better cartilage, I'm working on these genes. And that's what we're doing now. Next slide. Okay, so the inflammatory response. Next slide. Oh no, not this. Oh good. Oh, too much information. Oh, right, Katie? Too much information here. Anyway, what I want to tell you is that there's 102 kinds of arthritis. Okay, arthros means joint, itis means inflammation. What I'm primarily interested in are the mechanical ones, the wear, tear, that thing. I don't want the inflammatory arthritises because they eat up the cells. Okay, so rheumatoid arthritis, psoriatic arthritis, those things, stem cells don't work very well for. They will someday, but not now. The take-home message here is up here, okay? And I want you to understand that inflammation, like regeneration, is a process. Okay, so you have the acute inflammatory phase from the time of injury to the first 24 to 48 hours. If you can do anything, avoid the anti-inflammatory then, because that's when you're releasing those growth factors. Now, if you want to take an anti-inflammatory from 48 to 72 hours to 3 weeks, you can. But the problem is that that period of time is the only period of time your anti-inflammatories will work, and we're going to see that in just a second. Because the other stages that we're talking about, the chronic inflammatory and the burnout and the pro-inflammatory phase, your Celebrex, your Motrin, they don't touch it. 85% of inflammation is not treated, but we can treat it. Next slide. So I use Braveheart as our example here, and I can because it's my lecture. And basically I'm Scottish, so let's go. So we're going to describe inflammation as the scene in the battle. And this over here represents Longshanks, and this represents Mel and the boys, okay? Now these things over here, we're looking at the lining of a knee, okay? So the joint would be over here. Well, the cells that we need to heal that knee are right here. Did you know that your stem cells are there? Wow, that's cool, because I could never transplant enough cells. Okay? What we're trying to do, what people don't understand is, the wear got ahead of the repair. We just nuke it and make the repair ahead of the wear. Eventually it falls back so that we develop equilibrium. How does that happen? Well, when I put stem cells over here, I get Longshanks both ways. Okay? So I get a beachhead here, and then I can knock them down to this so that now I can let these boys in. So using the analogy of the war, we were talking about your Cox-2s. Oh, please, please, please. It's up here. No. Anyway, that's your Motrin things. In terms of the battle, they're your archers. So the first thing he does, he calls for the archers to come in. And they shoot their arrows. And those arrows last as long as they got them in the quiver, right? That's not a very long time. So your Cox-2s only work for that 3-week period. Max. Boom. Okay. I'll get going. But the point is they last for 3 weeks. That's it. It's over. Then you got the cavalry coming in, right? Those are these other bad things. That's this. Okay? All your anti-inflammatory is that. So the cavalry comes in. That shows you what your cartilage, what these things do, these bad boys. They come in and they create holes. You can stop that with things that you do. Okay? Then behind that is the army, and they wipe out everything else. So what I'm trying to show you is that inflammation is a process, and guess what? There hasn't been a new anti-inflammatory in 20 years, right? Right. There is now. The best anti-inflammatory ever made, is now on the market. That's called A2M. A2M is alpha-2 macroglobulin. Your body makes it. It's made in the liver. It takes care of every one of those. Every one of those. Okay? And it binds them down for 6 months to a year. We also get it out of your blood. These little injections, these hyaluronic acid, well, the difference from here to here, it shows you just what hyaluronic acid can do to these. It can knock them down too. Okay? Next slide. We'll get going. We're almost done. So the last part of this is talking about nutrition and things that we can do. Well, we talked about this osteobiflex, and you hear all this garbage, it works, it doesn't work, whatever. So I went to the horse's mouth, and I talked about the cells at the North Carolina State. The way we take the chondroitin orally, most of it's thrown away, okay? But if you inject it, or take it rectally, or put it under your tongue, it's totally different. So remember those recommendations I was telling you about? If we look at how you do it, you get a whole different picture, okay? That's what we need to start looking at, okay? Because chondroitin and glucosamine are part of it. And remember I told you that arthritis is a cartilage bone problem? Well, you better deal with the bone, okay? You need to have your vitamin D, you need to have your calcium and all that check. So when you look at my criteria, that BMP was, I make sure everyone has a calcium, a protein, a vitamin D, and a bone density before we do stem cells. Last slide. Next one. Okay. So I love this meal, but everything about this meal is inflammatory. So our diet can create inflammation. Foods that are high in alpha-lipoic acid, okay, that's the hot dog. Gluten, okay, which is from wheat germ and a binding agent, and the bun, 60% increase in gluten in the last 20 years. Gluten is very, very, very inflammatory. And the other are the carbs. They're also inflammatory. So our diet can play a role. They can activate or deactivate those genes. Next slide is it. So basically what I'm trying to tell you is that we don't want to think out of the box. There shouldn't be a box, okay? Because what happens is what the historian watching or summarizing what Paul wrote, he said, and men became like-minded and genius fled. If we all are the same, we get mediocrity. Mediocrity does not lead to excellence, okay? And excellence leads to innovation. Thanks so much.
There will be time for questions after the end of our program, so please, please think of those questions you want to ask Dr. Eglinton. I want to introduce next Dr. Mogannam. His name is hard to pronounce. Born in San Francisco, obtained his bachelor's degree from UCLA, and then received his MD from Chicago Medical School. He finished his residency and fellowship at the prestigious University of Southern California. Dr. Whalen, on the other side, born on the United States Naval Base in Yokosuka, Japan, and raised in upstate New York. He received his bachelor's degrees in psychology and biological sciences, minoring in chemistry, from California State University, Fullerton. Dr. Whalen received his MD from the University of California, Irvine, and completed his residency at the University of Southern California. Together, Drs. Whalen and Mogannam founded Flexogenics, with locations in Los Angeles and Cary, North Carolina. And I'm pleased to introduce them tonight to speak with you about their experiences with stem cell therapy and orthopedics.
First of all, I'd like to thank Dr. Ellis for inviting us here. And what a great talk there by Dr. Frankenstein, Dr. Eglinton. Anyway, my name is Dr. Mogannam, as Dr. Ellis said. This is Dr. Sean Whalen, and with Iris Chin, we're the co-founders of Flexogenics. So we're going to have a talk, how would I talk to say, a consult with a patient. So that's kind of how I'm going to approach this talk tonight. So first of all, next slide. So the first slide says osteoarthritis does not happen overnight. Well, really, what does that mean? Well, commonly what I hear is that somebody wakes up one day and they have knee pain. They go to the doctor, they get an x-ray done, and they say, you have osteoarthritis in your knees, bone on bone. Oh, I have osteoarthritis. Well, the truth is, it didn't happen that day. It didn't happen that week, that month. It's something that happens over years, not decades. In fact, we think it probably starts somewhere in your 20s and 30s. Next slide. Nice ringtone. So what are some common symptoms of osteoarthritis? Some of the common symptoms include, you might have experienced besides pain, include stiffness, muscle weakness, joint swelling, decreased range of motion, and when it gets to the point where you have bone-on-bone contact, you might feel grinding, popping, maybe even walking a bit severe. Next slide. So this is an illustration of the stages of osteoarthritis, in this case here, a knee. And what we see in our office, probably Dr. Eglinton, and what we definitely see a lot is we see people at the last stage there, the fourth knee there, at advanced osteoarthritis. And that's fine, we like treating people at any stage, but that's what we commonly see. But what we want to do here at Flexogenics, what our approach, what we want to do for the future, is we want to start treating people at that second knee there, that early osteoarthritis, where you just see a little bit of inflammation. And kind of how I kind of came about that is that Dr. Whalen and I, we were setting up our new x-ray machine, And just to test it out, we took x-rays of our knees just for fun. Well, it wasn't just for fun. It turns out that both me and Dr. Whalen both have osteoarthritis of our knees in the inner part of our knees. And then I just got this idea, thinking, well, why do we keep treating people at that last stage there? Why don't we start treating people at that second stage and be more preventative? And so that's, even though we still want to treat people at that fourth stage there, that advanced stage, we want to start early and to make this as a preventive kind of treatment. With people being more active these days, with different kind of fitness routines and what have you, I think that's the stage. I think in the future we want to be able to start treating people. Next slide. So you are not alone. And what does that mean is that over 50% of people over the age of 65 are usually symptomatic with osteoarthritis. But in fact, 80–90% of people actually have x-ray evidence of it. I mean, I wasn't symptomatic, and I just happened to, just happy-go-lucky take some x-rays, and I have it. So, and I'm sure a lot of us, most people here, we all have it in some way or shape or form. Next slide. So what are common treatments for osteoarthritis? Well, the first one that we like to be able to start with anything when it comes to your health, is diet and exercise. And I know how hard that is to be able to do that and to be able to accomplish your goals that way. But if that fails, there's always physical therapy that's commonly used. But what we frequently fall back on are certain medications, including anti-inflammatory medications like Advil, Motrin. Also narcotic medications like Vicodin. People here, who's had a steroid injection in their knees here? Steroids, okay? And then the ultimate treatment is a total knee replacement. And really what the common theme is with a lot of these treatments is that they don't actually treat the osteoarthritis. Osteoarthritis is a wear and tear disease, like as Dr. Eglinton alluded to, and you lose cartilage. Well, these treatments are kind of like a Band-Aid. Like, for example, just the anti-inflammatory medications, it's trying to reduce inflammation, okay? It reduces inflammation, but it's not treating your osteoarthritis. The steroids, again, it's masking the symptoms, it's reducing inflammation. And then you have the narcotic medications like Vicodin, which basically just drug you up, essentially. And so these treatments, they're not 100% risk-free. In fact, there are a lot of risks. For example, with a lot of these anti-inflammatory medications, such as Advil and Motrin, you can have ulcers, you can have GI bleeding, there's many deleterious side effects that you can have with these. Steroids as well. It can weaken the tendons and ligaments in your joints and lead to some kind of major knee injury. And then again, the ultimate treatment there is being a total joint replacement. Next slide, please. In fact, 1 in 3 knee replacements may in fact not be necessary. That's a scary statistic to really digest. And in fact, osteoarthritis complications account for 1 death in 300 patients. And what does that mean? Osteoarthritis does not cause death in itself. It's a wear and tear disease. You lose cartilage. But a lot of other things happen. You fall, you break a hip, you're in the hospital, you get a clot, goes to your lungs, you can break a wrist, you can hit your head, you can injure your spine. Those are the complications that happen because of you don't have the normal wear and the normal strength in your legs because of the wear and tear from the osteoarthritis. Next slide.
Switch here, I'm going to take over. I'm Dr. Whalen. So I just wanted to mention in relation to something that Dr. Eglinton said, and I'm going to refer to my note here, he said stem cells, not a fad and not the future. And I just want to reiterate that the future is now, because we're beginning to use these stem cells much more proficiently and much more commonly. So the Flexogenics approach to all of what Dr. Mogannam has just described. We have an outline here. We're starting off with pluripotential or pluripotent stem cells that Dr. Eglinton talked about. These are the seeds in the grass. Then PRP, which is platelet-rich plasma. We're harnessing the beneficial features of growth factors and cytokines. We're using these elements to accelerate the process of healing and regeneration. You hear about athletes that have a injury that's not necessarily career-ending, where they want to accelerate the healing process and get back as soon as possible. And that's what we're doing. We use the scaffolding agent, which is, in this case, hyaluronic acid. This is used in many different applications in osteoarthritis on its own. But in this particular application, we're using it to keep the seed and the growth factors in place, like the straw that Dr. Eglinton mentioned. We use image guidance. We don't just feel the landmarks on someone's joint, whether it's a knee or a shoulder or anywhere else, and blindly advance a needle. We are very adept at recognizing the landmarks visually with ultrasound and fluoroscopy, and we make sure that this procedure is as accurate and precise as possible. This increases the effectiveness of the outcome, and this also reduces the likelihood of any potential side effect of the injection. We follow this with advanced physical conditioning. In the case of knees, we are using innovative strategies to allow patients to exercise more without causing damage to their joints. And I'll show you an example of that in a moment here. We also use TENS for muscle stimulation to inhibit pain pathways, and in cases where it benefits the patient, especially the knee patient, with asymmetric narrowing of one side of their knee joint, we'll use specific bracing techniques to decrease the pressure on that side of the joint. In terms of recovery, because it's a minimally invasive procedure, and it's nothing like a total knee replacement or even an arthroscopic meniscectomy, which I'm sure many people have heard about, the recovery is very minimal. The downtime is very limited. We actually will recommend that patients have only 2 weeks of limited strenuous activity following this type of a procedure and implanting stem cells. And there is a much reduced risk of complication compared to the other surgeries that I mentioned. Next slide. So just in summary, I won't labor through this slide again. It just kind of summarizes all the things I just discussed. Next slide. So I alluded to advanced physical conditioning. These machines that you see here on the left of the slide are called anti-gravity treadmills, as they're labeled there. Ultra-G is a company that was based in NASA research, and essentially they were working on developing ways to mimic gravity for astronauts that were in space, because they would undergo muscle atrophy without the effects of gravity. Well, that was in a long-term think tank, and then the son of one of these researchers said, well, what would happen if we flip the switch and reverse this? Well, we increase gravity. So, reduce gravity. So what we've done here, what this machine has done, is in that chamber that fills up with air, we have a differential air pressure that will actually effectively make the patient feel like they weigh less than what they actually do. So if a patient's carrying extra weight because they're not moving very well because their knees hurt, they begin this unwinding of this vicious cycle. And what we do is we start treating the knee joint, but then we have to get you moving again. So we want to get the cardiovascular benefits and the biomechanical benefits of exercise. And that's what this machine allows us to do. Because when you're walking or running on this machine, you can be effectively feeling as though you're about 30% of your body weight. And what that's going to do is mitigate or reduce the damage that's occurring to those very important stem cells and new tissues that we just helped to regenerate. Next. I mentioned bracing. This is an example of a brace, and these braces are designed to use physics to undo damage that's occurring selectively to one side of your knee. Most times what we have is the inside or medial aspect of our knee is going to hurt more. Most people complain of knee pain here compared to the outside. And that's because 90 to 95% of us wear out the insides of our knees faster than the outside. It's just the biomechanics of how we walk and support weight. These braces help unload the pressure on that knee joint. By pushing on the outside of the knee, for instance, we can go ahead and, by microns, by very small amounts, open that knee joint while you're walking or standing on that foot. Sometimes it's lateral joint space, so we can work on that as well. And again, this helps reduce the damage that's occurring continually every day on these very delicate surfaces of tissues that we've regenerated. Next. Go ahead, next. So I have on the next slide here, we have some testimonials. I'm not sure if they're going to play, but we're going to try. We may not have audio. Oh, you're clicking the blue arrow. If you just click the yellow arrow. There you go. Oh, you're on the orange pen right now. You gotta get up a little bit more, just on the yellow arrow. Up a little higher. Oh, right there. Go ahead and click that. All right, it may not play. These are happy customers. They're telling you all about how good their knees feel. Because of the treatment they've received from us, they're very satisfied, and they want to tell you all about it. But they're not going to be.
Are those OA patients, or are they wellness patients?
These are all osteoarthritis patients. So these are all patients who came to us specifically with knee pain. We diagnosed them with osteoarthritis, and they had imaging evidence of osteoarthritis on the X-ray and ultrasound. Okay, so skip to the next couple slides here. Nah, it just doesn't work in this format.
And you bill that to your insurance company?
Yes, so as Dr. Eglinton had mentioned, these treatments with stem cells and PRP are not necessarily FDA approved, and insurance is very slow to follow suit. So while these things are very widespread in Europe, China, and all other countries, and many insurance companies or medical infrastructures will pay for this type of treatment, in this country, we're very slow to come along. So insurance companies will generally cover the procedure itself, which is an image-guided injection, and any sort of diagnostic follow-up and preliminary workup. But the actual cells and PRP itself are generally not going to be reimbursed. So there is a bit of financial burden at this time for the patient, roughly half to 2/3 of the cost in these cases.
Sir?
Yes.
What would the contribution be if you had to have a total knee replacement in the hospital?
I think Dr. Ian would have a better figure on that. You mean the cost or the contribution on the part of the patient?
Contribution on the part of the patient to a $60,000
I'm
knee
sorry, I
replacement.
didn't mean to initiate this
It's
conversation
okay.
yet, because I know it's a big part of
Well,
it, but...
Because my wife's had the stem cells, and the
Yes.
cost is very minimal, I think, compared to she had to go to the hospital and have a total knee replacement.
And it's a perspective issue, and it has to do with understanding prevention and taking personal responsibility in your health and what that's going to mean in the future. And yes, most people don't plan on having a total knee replacement, and those costs are not on the forefront of our awareness because of that. But you're absolutely right. Depending on your insurance, those could be substantially higher costs.
I'm sorry.
No problem. So this is kind of closes letting you know who we are, where to find us. Right now we do have offices in Cary, North Carolina, as well as Los Angeles. And we're opening a new office in Charlotte, North Carolina, in the very beginning of March of this year.
Thanks, guys. Thanks so much. I'm going to speak very briefly on why this interests me. You guys know I'm a surgeon here in Asheville, and I do varicose vein surgery. And I also do some minimally invasive aesthetic treatments. And a couple of years ago, I started a wellness program. So it fits in 3 ways with me, stem cells. One, aesthetically, in my aesthetic practice, I do now PRP and stem cell facials. So just like stem cells can grow new cartilage, they can also grow new heart muscle, nerve tissue, all kinds of cells in the body. Well, skin cells included. So this slide demonstrates that stem cells and PRP can also be used for wound healing and for improvement in skin quality. And skin quality is elasticity or collagen growth in the skin and general appearance of the skin. So it's an aesthetic treatment in my office. I don't do joints and orthopedic stuff like these guys do. So, but number two is in our wellness practice, which is called medAge, which is what we call our medical age management practice. And Dr. Wiltsey over here is our medical age management practice doctor. And Trina Pistor is our nutrition and exercise trainer. All of that comes into play with wellness as well, not only with joints, but with the rest of the body. And so I'm intensely interested in how do we keep our joints healthy. And so I really like this idea of the wellness aspect of keeping joints healthy, and in addition to the heart and the brain and the breast and every other part of the body. And then third, my own knees and my shoulder, and there's a joint in my foot. They're all starting to hurt. And they're limiting me, and I'm an athlete, and I'm very active, and I want to continue to be active. I'm 51, and when I'm 61, and 71, and 81, I still want to be riding my bike and getting out and doing the things I want to do. And if I have to get a knee joint replaced, I can't run and jump on that thing. I want my own cartilage. So I'm going to start doing stem cell therapy for my joints to replace my lost cartilage, because I know it's thinning, wear and tear. So, next slide. So I use in my office for the aesthetic part, for the skin part, a system that I get through Synergistic Technologies. Thank you again for helping us out with this program, you guys, today. And what that system does is it allows me to collect blood from my patients, and I have a couple of patients in this room who, if they want to tell you their experience, I'll let them volunteer that at the end. And collect blood, simple procedure, and then we process that blood so that we collect what we call the pure PRP. PRP stands for platelet-rich plasma. Plasma is the part of the blood that doesn't have the red blood cells in it. It's that yellowy part at the top. The red blood cells have been taken out of this. And then the purified part is that we want the plasma that is rich in platelets, because platelets are part of this blood system that release the cytokines and the growth factors and all those things that make the stem cells differentiate and turn into new skin cells that make new collagen and better collagen than the older cells that are in there right now. So we do this using either a microneedle roller after we spray the PRP on the face or the chest or the neck or wherever we want it, and then we roll this little roller across the skin that has tiny little prickles on it, and it pokes a little hole in the skin, allowing the platelet-rich plasma to get in, and then it does its job. Or we do a laser resurfacing, which also pokes little holes in the skin and allows the platelet-rich plasma to get in and do its job. So, next slide. This is one of our first patients, and you can see the little roller here on her neck. It looks like a little pasta, ravioli maker roller, but it's got spikes on it. And it pokes the little holes in the neck and the chest and the face, and we you can see that shiny stuff on her is the PRP. Next slide. And then we put this very cooling, lovely, hyaluronic mask on the face that feels really good. Next slide. How this all fits into what we do in our office as in our wellness program. Aesthetics, we call that the icing on the cake. You have to be nutritionally fit, you have to be physically fit, you have to be hormonally fit, you have to manage the stress in your life that leads to inflammation, that breaks down your DNA and makes you old, or ages you. And so it all fits together as the cogs you see here working together. You can't just pick one or two of these things, you have to do all of them. And that's what we do, we help you do all of them. Next slide. Oh, this is our hormone slide. Hormones are a really, really, really important part of staying healthy. And if you want to know more about bioidentical hormone replacement therapy to stay healthy, talk to us or look at the information on your table. Next slide. And being of proper weight and fitness is important too. We've got information on the tables about that. Other thing I want to tell you about information on your table. Look at the little, let me see this here. This thing here. Fill this out so we can know who you are, how you heard about this, and what your interests are. And we're going to put this all in a pot tonight before you leave, and we're going to draw one out, and you get a $100 gift certificate to the restaurant here in the hotel called Brew, which is one of my favorite restaurants in town. It's an independent restaurant, and the chef here, executive chef, is Randy Dunn. He makes amazing food. It's almost all good and healthy if you pick the right stuff on the menu. So make sure you fill that out. And where's the thing they put it in, Katie? They're going to give it to you?
Yes.
And we're going to draw that in a few minutes. But before we draw that, we're all going to sit at the table here and you guys ask questions. We're going to send this microphone around. We want to hear your questions and answer your questions specifically. Turn to the next slide. That's it. So fill out your papers. Katie's going to collect them. And Trina, Rebecca, you want to hold this microphone?
Sure.
While they collect? Or you? Yeah. And when people have questions, raise your hand, and Rebecca's going to bring you the microphone.
Hi, thank you very much for this interesting evening. There was a lot of talk about knees. And my question is, what about the application to hips and hands, fingers?
Dr. Eglinton?
Yes. Basically, growth factors and stem cells can be used for anything. It's a blank cell. It can be used for anything. In my particular practice, I've used it for hips as well as shoulders. You know, is there anyone here that wants to volunteer to say something about their hand? Okay.
What about wrist?
We've done it wrist as well. You can do it in hands. And the people that have just raised their hand, you can go and talk with them. They'll give you a fair and honest assessment. Again, you know, we do it in hips. And like the doctors of Flexogenics, we use image as well. You have to, especially on the hip. But one of the interesting things about joints, and I really admire the fact that they do that as well, and I think we all know why, 70% of the time when most people inject your knee, they're not on your knee. So
You use ultrasound guidance.
well, you can use ultrasound, you can use CR. But we've used it in hips as well. Of course, my studies were primarily in knees, but I've also used it in heel cords. And one of the papers I'm writing is on segmental defects in heel cords. And we've done several marathon runners, elite athletes here in the area.
Hundreds, maybe thousands of professional athletes every year get stem cell therapy treatments for not just their joints, but for healing of all kinds of musculoskeletal injuries. You don't hear about it so much, but they're getting it.
And I'll just add that we were just discussing before the meeting tonight, we've treated shoulders, hips, elbows, wrists, and and even most recently, I treated a gentleman who had a diabetic feet, Charcot joint, where he's losing the feeling due to diabetic neuropathy, and he's having great success with neural regeneration as well as connective tissue.
I also want to give my own personal story here, because I'm kind of a fitness enthusiast. At least I think I am, and other people think I'm crazy. But I tend to ruin my joints quite a bit because of all my activities. And so I have issues with my elbows, with my shoulders, and then it looks like I have issues with my knees too, even though I'm not feeling it. And so I've actually received the treatment for my elbows, for my tendonitis in my elbows, and also for my tendonitis in my rotator cuffs in my shoulder. And I can't tell you how much it's helped me, because I like to be active. I'm about to be turning 42 in February, and I like to maintain this level of activity as long as I can. And so I don't want to get to that fourth knee there that you saw on that slide where it's advanced arthritis. I want to keep it at that second knee, if not bring it back to a near normal state as best I can. And so I guess what I'm saying here, I'm not just the president, I'm also the patient. So.
I just have a general question for any of you who has the answer. What is the source of the inflammation that leads to the bone loss? Does it start with the tendons? Is it in the bone? Or is it the inability somehow because of inflammation? The bone cannot no longer make the cartilage because of inflammation. Where, in other words, you guys are doing something great to fix the problem, way beyond surgery and masking medications. But where does it go back? It seemed like in the mummies, 400 years ago, we started seeing osteoarthritis. What was that? The onset of ground wheat flour? Was it gluten, like Dan said, or is it biological issues coming from the gut, from overeating?
Yeah, Don, I'll answer that. And I think it's a fascinating question as well. I think Sean or Paul alluded to this, that most of the arthritis that we see starts on the medial side of the knee, and that's not by accident. And when you look at the knee, there's a condition called SPUNC, spontaneous osteonecrosis of medial femoral condyle. And what happens is you start seeing changes in the bone before you ever see changes in the cartilage. And on an MRI, you see what we call increased signal. Now, the radiologist will call this acute marrow edema, but it's basically the same thing. And we see this in these 30 or 40-year-old people. And I know that if we don't do something, that knee will go to hell in a handbasket in 5 years. Because what happens is that when you have this pressure, and the reason it happens on the inside side of the knee, if you look at gait, when you're walking, just before you put your foot down, your other knee is at maximum bend, and you're just about to push off. Well, if you look at stress analysis done in Finland on cartilage, what you see is that if you have loss of your core, this is going to make everyone happy, or it's all about the base, Well, on the core, as we get older, what uniformly changes? What uniformly changes is our core balance. And so what happens is you get torsion, and you get a shear moment. And so always associated with this is the tear in the posterior horn of the medial meniscus. And for years, everyone said, oh, it's the torn cartilage that creates this. No, the cartilage is a result of, the meniscus tear is a result of, not the cause of. So by doing some of the things that everyone's talking about tonight, hopefully what we can do is reverse that. Now, if you look at the study that came out not this year, in December, but last year, from England, that was in New England Journal, and this is very important to all of you. What they did is they had two groups of people. They had those groups of people that just had exercise, and then those groups of people that just had surgery. And guess what? At the end of the year, they all looked the same. They all went back to pain. And the reason is because you're not doing anything for regeneration, Don. That's the problem. So as I said before, it's a complex issue. I think it starts in the bone because you get the pressure, you get nutritional changes, that creates the cracks in the cartilage, then that creates the debris of the cartilage, which activates the inflammatory cytokines and causes the damage to come down. So we have to treat them both. But what I'm trying to say here is not that exercise isn't important or weight reduction. You lose 5 pounds, your knee will feel a difference, but it's not the only answer. Okay, that's what I'm saying. So wellness has been very well described here. Wellness is basically absence of disease by definition. So in my age group, what we're talking about is not wellness, we're talking about health maintenance. And so when I hear wellness programs for my group, I know they don't know what they're talking about. These guys do, but everyone else. And the reason is because the cow's already out of the barn, out of the corral and in the pasture, ready to get slaughtered. And the best I can do is get that cow back in the corral, build a higher corral, a stronger corral, but eventually the cow's going to get out. That's what I'm saying. Eventually we'll all get killed. And Don, you make an interesting point. Two things more, and I'll shut up. But one is there is an ASPN gene that's been identified that is specific for arthritis, and some people carry that. And with the mixing of the gene pools we have, that stirs that up. I didn't tell you my real reason that I'm so passionate, and many of you know this, but I have a grandson with a potentially fatal blood disease who's 7, and I cut my arm off for him, and he has thalassemia major, and he may die without a stem cell transplant. So I have a personal vested interest in this. So, you know, to me it's more than anything else is what we got to do. But getting back to this ASPN gene, and what I was trying to tell you with the regulatory genes, you hear on ads on TV, it's, you know, genomic testing for cancer. Guess what, guys? Everything is going to be genomic. You're going to be treating bacterial infections genomically. You're going to be treating fractures genomically. There even dentistry is treating cavities genomically. Everything will relate back to the gene. That's where we're going, and it makes sense.
Have there been any studies or trials with low back weakness?
Dr. Billy Henna, who's at Duke, and who's at MD Anderson, we've worked together.
Could you repeat the question, sort of?
Okay, people are asking about back. And I think what Paul and Sean were showing, as well as Laura, is that when we look at disease, we have to look at disease differently. We talked about a paradigm shift. So it's not just a cartilage problem with arthritis, it's a bone cartilage problem. If you look at a rotator cuff tear, those are nutritional tears. It's a bone tendon problem because the tendon gets its supply. In the case of cartilage, in the case of the nucleus pulposus on the disc, before you get a black disc showing that it's dead, you already have changes in the end plate of the vertebral body. And so we know now that the disc gets its nutrition from the bone. So we're working on ways to go through the pedicle, like you would if you had a compression fracture, and go in and put the cells in that way. Real interesting study out there where we can take someone and put them in an MRI, okay, under an electronic field. I can inject the stem cells and I can put iron on those stem cells. They will collect where the area is. Then you use a pulse generator and you can pound them in without even using a needle. Not studies done in mice. But right now, if you inject a disc, you pooch the disc, it leaks and you got a problem. So we want to go above. But we're working on it. They're working on a lot of things. But we have to look differently. So when you're looking at a face, you're missing collagen and elastin. That's what you miss. There's a bunch of different ways you can treat it, but ultimately, what Laura's doing is the way to go. Because then you got an endless supply of collagen. It just keeps going. And that's what's missing.
And it's yours.
It's yours, yeah.
Could you explain the hip treatment with the stem cell treatment? How does that work and how successful is it at the moment?
We have people in this room tonight that I've done hips on that are plus and minus, okay? And they may be willing to raise their hands, okay? Hips don't do as well as knees because by the, hips, by and large, do very well as total joints. I mean, they recover very quickly, and, so a lot of people just prefer to go ahead and have the total hip. But in terms of what we've had here is, by the time I get the hips, they're pretty much gone. And we're trying to make, chicken soup out of stuff. But they have gotten relief. And there are people in this room that I've done it, and they've gotten relief. And there's some people that are dogging a little bit, dragging a little bit. And, you know, there's some people that, you know, would just need to go ahead and have it done. But, you know, what are you losing? You see, I mean, you can always go back and have your total. See, that's the whole thing. Once you have a total, you can't go back. That's it. It's over, you know. And so, yeah, it's out of your pocket. And as Sean and them say, it may be paid for. I personally hope it isn't paid for by insurance. Because right now, we can keep the cost down relative. You let the insurance company get this in the hospital, which they would do, that's not a bad thing. That cost will go way up. But that's just my opinion. Other people may not share that.
I'll add to that. We have a lot of patients, knee patients, who come in and they've already had one knee replaced, and they're there specifically to avoid that same fate for the other knee. And I think what this goes back to is some of the paradigm shift we've been talking about in terms of the perspective on this issue, and in terms of degeneration over a lifetime. And it's about preventing these things before they get to the point where the outcomes will be so mixed, where we won't be likely to have as such a good outcome. And that has to do with systematic preventive maintenance on a regular cycle.
Interestingly, that's when we talk with each other, that's what we talk about. We talk about how can we, not only for ourselves, but for our patients, how do we help them live happier, healthier, more vital lives with their own cartilage? And I just met these guys a couple of months ago, but when we met, that was the conversation we had. And it just fascinated me so much because I was facing that problem myself at the time. So in a sense, it was a really selfish thing of me to really want to get to know them better. But then once I did, I thought, you know, I got to share this. This needs to come to my family, where my patients are. And I'm going to start my knee injections this year. I'll be 52 this year. It's high time. I wish I could have started when I was 42. But it really wasn't. We didn't have it then. We have it now. We can do it now. And it's really relatively inexpensive. And if I can continue to run and jump and play on my own knees for the next 40 years, that's what I want to do. And it's yeah.
You're approaching an area that really is my question, and that is, I'm pretty sure I have arthritis in my hands. No one's ever diagnosed it, but I have pain in the joints, and so I presume that's what it is. I'm self-diagnosed. It doesn't prevent me from doing things, so I haven't done anything about it, but I guess my question is, when does one go and seek professional help? And how do you go about it? Do I tell my family practitioner when I go for my checkup, gee, my joint seems stiff, should I see someone? Or how do you go about that?
Well, there's the problem, because I think so much of the time the reaction from primary care docs, and hopefully this will change, and I hope there are either some in the room tonight or you will go tell your primary care doctor about this when you see them next, but that's often it's treated with medication, with a COX-2. You know, he mentioned the COX-2s. What he meant was COX-2 inhibitors, and those are anti-inflammatories. But what are they really doing? Are they slowing down the osteoarthritis? Are they masking something? I think maybe these guys can talk a little bit about that.
Unfortunately, we in the medical community are trained to respond to a complaint, to fix a problem, respond to disease processes. And the truth is, this is a completely upside-down way of thinking about this. It's understanding that the process is occurring before it causes you issues. There's a precursor. The stage is being set for what happens later. So I have a patient had one knee. I'm sorry to keep going back to knees, but it's what we see most commonly. The patient says, only my right knee hurts. So I take pictures of both knees, because I have to point out that the same thing is going on in the other knee. and it just hasn't started to bother me. So it fits in perfectly with this concept. Arthritis does not just occur at a certain age, and it does not just occur overnight, and you don't have to accept that it will occur at a certain point. Just, I give an analogy, people like dental care. 200 years ago, people didn't brush their teeth regularly every day, twice a day. And it's not, no one would challenge that thinking now. So we have to challenge this thinking. We have to indoctrinate and retrain the conceptual awareness about what's happening in the body.
And to give to get back to my own personal story here, I was symptomatic on my elbows and also in my shoulder, but my knees, I just happened to just run across it, and I was not really feeling any issues with my knees. But if you're going to practice what you preach, you better start owning up to it. And when we came up with our concept of trying to be more, taking on a more preventive approach, well, that's when I decided to own up to what we're talking about and get the treatment for my knees. So for me, I wasn't symptomatic, but I got the treatment anyway for a preventive nature.
And it's similar in our practice. We look for disease markers of heart disease before you have symptoms of heart disease. Let's address it before you have symptoms so that we can actually reverse it. That is possible in medicine, reversing diseases that killed your parents and your grandparents.
I think for me, too, the issues I deal with as an orthopedic surgeon is pain and function. Okay, so your pain such that it's limiting your function. And that's one thing that you can, will bring you to the doctor and see. I mentioned biomarkers, I mentioned fat, neck-to-neck complex. That is a very, very helpful tool because if fat is present, inflammation is present.
He's looking for a marker before you have symptoms.
Right, it's a marker so you can look at it and you can assess your treatment. Because if you get it early enough, like growing grass, you may not need everything, okay? So I look at my yard, I may not need seeds. I may just fertilize it. Heck, I may just water it or aerate it, okay? So one of the things, if you want to do what we do, is you have to know the biology to see what's missing. Remember, I started off by saying it's replacing what's missing with what's missing. So you need to understand that, so you have to have the biology. And the markers, I've had stem cells. I wouldn't sit here and tell you. I've had it in my back. I've had it too.
I'm sorry, Katie tells me we have time for about 2 more questions.
Oh, Katie. What a funny duck, Katie. God.
I don't have a question, but I just want to share. I'm a patient of Dr. Eglinton.
Oh, no, God.
You stuck with me. 2008, this science or medicine was not available. My hip was shot, and I was in my late 40s. I was pretty hard on my body. I had a Birmingham hip replacement, which it's no longer available. That's worked fine, but it took a long time to heal from that. My knee, after 5 knee surgeries, I had a stem cell done about 3 years ago. Best thing I ever had. I'm glad that I did. I wish it was available before, but it wasn't. My left hip has gone, bone on bone. In September, I didn't think about anything else. It was so painful. I didn't think about a hip replacement or anything. Stem cell. Went to see Dr. E. Within 2 weeks, my pain was gone. I could just really see a difference. What's happened now, I think I hurt myself, so I'm in pain again. But I'm ready to try something else because I don't want to have another hip replacement. I don't want to have to go through almost 2 weeks in bed and learning how to walk again, then having to go to physical therapy for about 6 months, being on light duty for my job for that long, and then strengthening the legs and the muscles and all that. So this is something that's worked for me, and I will continue to do it till the doctor says, hey, there's no other choice. The hips don't do as well as knees, and then I'll have to have that. But until then, I'm going to
and know that none of us up here are anti-medication or anti-surgery. We're surgeons and we're physicians. And we're not operating on the fringe. It's all science-driven here. And if you go to your doctor and you get some pushback, or they're not really up to speed on the whole thing, it's okay. You're getting information here, and there's lots more information out there, and you can always contact us to help you get through that conversation with your doctor.
Yeah, there are rules for like using anti-inflammatory medications or steroid in specific situations here, but it has to be really just not used like loosely, which I think it is. So.
Yeah, I'm like you, Dr. Ellis. I'm 74 and I'm living to be 100.
Amen. And not just living to be that old, you're
I
living.
understand that the unexpected visitor can come along, but I don't have time to worry about that. You know, I broke my leg when I was 7, and it must have grown back a ½ an inch because I started in football. I found out I could go to this side much better than I could go to that side. But anyway, I've run marathons for years on that shorter leg, and then I built it up finally, leveling the hips, which are really powerful, but not until the torque on the right side of my body wore out my right knee and a little bit of the hip. But anyway, I found out about Dr. Eglinton. I'm not a plant. You'll have to believe me. The nurse told me one day that I worked with. And I said, you know, I know when you lose your legs, for one, you're in trouble. It's hard to get the cardiovascular that you need. You know, I go to the Y every night or the other, and so he puts stem cells in, and it's about halfway there. And I'll do anything to avoid a knee replacement because, hey, I've got a long time to go. I'm having a great life. I would never retire. I don't understand that. So there's hope. There's hope. If you do the research and find out, and I'll shut up.
Thank you.
I have a question specifically about treating endurance athletes, runners in particular.
Mary's a marathon runner as well.
Well, I didn't start till I was 58, so I have a lot of catching up. But when you do the stem cell treatments, is the outcome often to say, maybe you need to pull back a little, or do you say, go for it? Do you encourage them to keep pushing?
So as Dr. Eglinton just mentioned a second ago, it's about pain and function. And we measure outcomes based on the subjective experience of those two things. And we want to see patients regain function. And that could be just getting up and down stairs without having to shuffle, or walking for an extra 20 minutes every day, or taekwondo, or marathon running, ballroom dancing, bowling, golf, tennis. Each person has their own set of expectations tied to what they want to regain. We encourage full range of activity. That's what we want to see patients regain. Patients will often ask, how long will the tissue last that we're regenerating? About as long as it takes to destroy it. So we want to keep the wear ahead or behind the repair, like Dr. Eglinton mentioned. So you're losing maybe 1 to 2% of your articular cartilage annually on a very steady state basis, just with normal wear and tear. A marathon runner, it's going to be at a higher rate. But what we're trying to do is regenerate or replace and restore what's being lost on a continual basis.
You know, all I need to do is get back in the spinning class. I don't need to run any more marathons or prove anything. I just need the cardiovascular, and that's a lot less than pounding my skeleton.
But that's the difference. What's being said here, and you need to understand that when you talk about a total knee or you talk about a total hip, okay, normal is not there. And I'm the best friend for the total joint guys. Give me the people you don't want. I'll fix them up, and then when they need them, I'll send them to you. That's fine. I mean, I put in thousands of totals. I don't think anyone in town other than one other doctor's put in more joints than I do. But to me, functional is being able to do what you want to do, when you want to do it, providing it's legal. And, you know, that's our goal, is to return you back. When I started out in training, Functional is being able to go to the bathroom. Functional is being able to go to the grocery store. That is not functional. And so, you know, that's what we want to do. But the total joints, they decrease pain and increase function. But, you know, what really ultimately determines whether you're happy with your vampire or you're happy with the guys who carry them, by the way, I visit them there and I know them, or up here, is based on two things. You know, our outcomes are based on our expectation and our reality, okay? And that's true in marriage or anything else, okay? The closer you can get your expectation to the reality, the happier you are. And they did a study on that in 2009 in Bone and Joint Newsletter. Who cares? But anyway, there's an article about it. But the point is that as doctors, we just keep lowering that expectation. And we do nothing to change the reality, because it is what it is. A total joint's a total joint. You know, everyone's up here moaning about their joints and they're falling apart. And, you know, I'm thinking, yeah, well, I wish I had that problem. You know, and you know, the point is, and I'm not belittling anyone, the point that I'm trying to make is that, you know, when you do regeneration, you actually change the reality. So yeah, I still lower the expectation, but I'm hitting that both ways now, okay? I'm lowering the expectation like I would for a total, but I'm also raising the reality because you're growing back what's missing. So guess what? You're seeing it. You're seeing it on their testimonials, mine, Laura's. People are happier. They feel better. And that's why. I mean, it's not rocket science.
What I would like to do with the email addresses, or the phone numbers, or whatever you put on your information card, is give you a follow-up message after this event and provide you with an opportunity to get more information from these fellows if you'd like it, and also send you a link to a video of this presentation if you want to go back and pick up on some other information. There was a lot of stuff that these guys talked about here that you might want to hear again, or you might want to make some notes and talk to your own doctor about. So make sure you give us that contact information. It's just for us. It doesn't go anywhere else. We're not going to give you a bunch of stuff you don't want. It's just a follow-up from this event tonight. So Katie is going to, and if you have further questions, don't hesitate to comment to us afterwards or contact us after we send you that email. And Katie, Dr. Yee is going to draw. He's going to draw.
I wonder if anyone wants a